Let's talk about psychotic disorders. So all psychotic disorders that we are going to discuss include abnormalities in the brain. And the idea is that within your brain chemistry, you essentially are receiving false sensory information. So false information about sounds, false information about things that you see, and to some degree false cognitions or beliefs about things. And that's really what fuels psychotic disorders. So the abnormal brain functioning includes a variety of common symptoms that we'll see across these disorders. These include delusions, hallucinations, what we call disorganized thinking, disorganized or abnormal motor behavior, which has to do with body movements, and what we call negative symptoms. And we'll get into more of these as we get into the disorders in this section. Do you want to talk a little bit about delusions? Because delusions come up quite a lot. And these are listed in order of how common these delusions are. So delusions in general being this idea of bizarre fixed beliefs, and you can't really change these beliefs. So even if you provide evidence that what they believe is not accurate, you can't really convince the brain otherwise. So these things are just unchanging facts, and you live your life around this information. So the types of delusions here are persecutory, which is this idea that you as an individual are going to be harmed or harassed or in some way pursued and hurt by others. And so everyone is a threat. Everything is scary. When we talk about paranoia, we're often thinking about persecutory delusions. This idea that like the FBI is coming after you. The next is referential delusions. These include certain gestures or comments or cues that are directed towards the self. So can be kind of like tics or just in general experiencing certain things over and over again in regards to the self. Then there are grandiose delusions, which is that the client thinks they have exceptional abilities or wealth or fame. This is the individual who thinks they are Jesus, or that they are the Prince of Persia, or they are some sort of like royalty that just hasn't been discovered yet. So this person is in charge of the world. There's erotomatic, which is the belief that someone is in love with the individual. So this person is in love with me. I don't care if there's evidence to the contrary. This person loves me. They are obsessed with me. We are in a relationship together. Then there's nihilistic, which is this that it's a paranoid belief, but not quite the same as persecutory, because nihilistic really is that the end of the world is coming. Some major catastrophe is going to occur and there's nothing we can do to stop it. So this person would be, for example, maybe a doomsday prepper because they think the end of the world is coming and it's coming soon. And then there's somatic, which is preoccupation with something that could be wrong with you physically. So I think I have cancer. I think that I'm having a heart attack all the time. I'm convinced that my stomach is going to fall out of my body. Like there's something wrong physically inside my body. And there's no physical evidence of this. There's not anything actually wrong with their body. It's just their brain has convinced them that there's something wrong in their body. Now, as we're talking through these delusions, you can tell already, I would imagine, that some of these things can be very culturally specific. And when we're considering what is classified as a delusion, it's super important for us to consider cultural context. So, for example, if someone is part of a religious community that does believe that the end of the world is imminent, that doesn't necessarily mean that they have a nihilistic delusion. It might just be indicative of their cultural values. And same with some levels of persecution. So if the religious community feels that perhaps like the devil is coming to get you, that may be a persecutory delusion, and it may just be a part of their religious background. So it's really important to consider these things in context of the clients. So let's talk about some other common symptoms across different types of psychotic disorders. So I'd imagine we've all heard of the concept of hallucinations. This is really where the brain is getting false sensory information. So they're very vivid and clear auditory information or visual information without an external stimulus. And this is very different than like hearing your own voice inside of your head or having the sense of like a person who's with you, who you've lost. So we have to be very careful about understanding how someone experiences something to determine if it is hallucination, because there's very much a difference between having conversations with perhaps a loved one that you've lost in the past and actually seeing and hearing them in the room. So when someone has hallucinations, they are as vivid and clear as if they were really in the room with them. And I had a client once who talked about how they felt like their brother who had died, was like a guardian angel and would manifest and have conversations with them while they meditated. As far as I could tell, that wasn't really a hallucination. Like, they didn't actually see the brother. They didn't actually hear the brother. It was just something that existed in their mind. And so you really have to carefully think about how to ask if these are things that they actually see and hear out loud, or if they are things that just exist in their mind. So the most common here is going to be auditory hallucinations, but sometimes they can include other sensory cues. So sometimes they're even physical touch. Thinking about hallucinations of maybe bugs crawling under your skin, or having sores or some kind of illness on your skin that makes you itchy or hurt. And of course, this can be visual hallucinations as well. But they must occur while you're clear and conscious. They cannot only occur while you're asleep or while you're dreaming either. We refer to hallucinations as the idea of positive symptoms. Positive symptoms meaning that there's something additional added to a typical sensory experience. So positive doesn't necessarily mean it's a good thing. Positive means that there's additional sensory information and experiences beyond what's considered typical. So then we have disorganized thinking or speech. This is like someone who changes topics all the time. They can't focus, they can't stay. We want to make sure that this is not indicative of something like ADHD or perhaps even mania associated with bipolar disorder. This is really a psychotic issue. And so they might have tangential responses to questions that are unrelated to your prompts. If someone has disorganized thinking and speech, doing an intake session with them is incredibly challenging because they are not able to connect their answer with your question, which is different than an inability to focus. So it's not that they can't focus on answering the question like in ADHD or mania, it's that their brain literally can't connect your question to the correct answer in their mind. And it's really hard to parse this out without taking some time with a client to understand their experience. Further, we have disorganized motor behavior. So similar to speech and thinking, there's physical activities that are not goal-oriented. And this is different than delusions that are related to physical symptoms where I'm thinking something like, oh my gosh, my pinky hurts, that means that I have cancer. Oh my gosh, I am associating this pain in my stomach with being pregnant, even though I couldn't possibly be pregnant. That's delusion. This is physical actions that are not goal-oriented. So this is the individual who takes off all their clothes in public. They might feel like they need to make the sign of the cross quite often. A lot of this is involuntary. And again, it's representative of a lack of ability of the brain to connect the sensory cue with the physical behavior that goes along with it. So it's not somebody who, for example, jiggles their leg because they're anxious. It's someone who cannot make sense of their physical activities because they're experiencing hallucinations or they're experiencing psychosis. The opposite of this is catatonia, which is where you have a very limited reactivity to your environment, making you stiff. You cannot move. no matter how much external stimulus you have. So then we have negative symptoms. These are different than positive symptoms. Negative symptoms meaning that these are things that take away from the typical level of animation and functioning in life. And again, we want to rule out things like depression as a cause for this, and it's really related to psychosis. So negative symptoms are where we would talk about something like flat affect, meaning that someone is not able to show a range of expression on their face. Someone has a lack of motivation for daily activities. They may have difficulty speaking or speak incredibly slowly. So in some of the clients that I've worked with who have had, for example, schizophrenia, some of them talk incredibly slowly because of the negative symptoms associated with their disorder. So the first disorder we're going to dig into in this section is schizotypal disorder. This is often associated with personality disorder. And so this disorder really specifically focuses on delusions. So we don't really have any hallucinations going on here, just delusions, which is really the difference between schizotypal disorder and schizophrenia, because schizophrenia includes hallucinations and schizotypal does not. It only includes delusions. So these delusions need to have been present for at least a month. This person has never met criteria for schizophrenia, so it's not a situation where they at one point have had delusions and hallucinations, and perhaps with medication interventions or just developmental changes in the brain, the hallucinations have gone away. That person would not meet this criteria, so they can never have had any kind of hallucinations going on. Apart from these delusions, typically they're able to function. They don't have this bizarre or erratic behavior. Again, that's really associated with schizophrenia. We want to rule out things like bipolar disorder, body dysmorphia, obsessive compulsive disorder, of course, schizophrenia. So if we note any kind of mood-related symptoms, they're brief and the delusions are pretty consistent. If they're longer lasting, we would need to look at either a different kind of psychotic disorder that includes more prominent mood features, or perhaps look at something like bipolar disorder with psychotic features. So what's the most prominent thing? Is it the delusions or is it the mood symptoms? And then, of course, as always, we want to rule out the influence of medications, substances, or other potential physiological causes. So we would be looking at a couple of different types of delusions here. There's erotomatic, which we've talked about, where another person is in love with that client and you cannot convince them otherwise. Grandiose, so I am the greatest puzzle maker on the planet. No one's better than me. I have the cure for cancer. I just haven't told anybody yet. So I have some sort of great talent or ability and the world just hasn't found me yet. There's jealous. So this is that paranoia that perhaps their spouse or their partner is cheating on them. And there's no evidence to support that. It's not actually happening. They just cannot be convinced otherwise. Persecutory, which is like the government spying on me. They have bugged my house. They have poisoned my water. There's some sort of conspiracy against this person. Somatic issues related to bodily function. So this is that I'm convinced that there are bugs under my skin. I'm convinced that I smell bad. But again, we want to make sure it's not hallucinations. So delusions, like I'm convinced these things are happening, but I can't necessarily feel them or actually smell them. I just know that they are true. We also have mixed, which is where we have multiple different types of delusions going on at the same time, or unspecified, meaning that it's a delusion that does not quite fit into any of these categories. This is a pretty rare disorder. The most frequent type of delusion is that persecutory type where someone's coming after you, someone's spying on you, someone's after you. There's not a major difference in terms of gender presentation, so equally likely, again, the DSM is pretty binary in the way of this, so no major difference from men and women. We don't have good information on individuals who are non-binary or transgender related to diagnosis. And then we have a specifier of with bizarre content. And so this has to do with something that's not derived from any kind of ordinary life circumstances. So this is like aliens are spying on my house, or Aslan from The Lion, the Witch, and the Wardrobe lives in my basement. So these are things that could not be connected to ordinary life circumstances. So brief psychotic disorder is the next disorder we're going to talk about. This disorder is the precursor to schizophrenia. And again, it's based on the length of time that the symptoms have been present. So for brief psychotic disorder, you have had one or more, and at least one of the first three. So delusions, hallucinations, disorganized speech, or disorganized or catatonic behavior, which is not terribly common, but certainly one of the first three is more common. So these things have been going on for at least a day, but less than a month. And eventually that person has been able to return to full functioning. So it's not all day, every day, it's just episodic. Again, we always want to make sure that this is not better explained by some sort of mood disorder, schizophrenia, meaning it's been going on longer than we're aware of, or potentially things like catatonia or medication interventions or substance use. So we want to make sure it's not side effects or physiological. And we have specifier options based on if it's exposed to, like if you were exposed to a great amount of stress, and so it's only been present in and after that stressful experience, and if they are only present due to recent pregnancy, in which case it's postpartum. So we have a postpartum brief psychotic disorder specifier that we can use as well. And so we always, especially with anything psychotic related, want to rule out substance use as an underlying cause. But the key here is how long has it been going on? So next we go into schizophreniform disorder. This disorder has the same diagnostic criteria as schizophrenia, the difference being the duration. So think about it, brief psychotic disorder turns into schizophreniform, which turns into schizophrenia. So these are the stages of diagnosis that someone goes through as they're working into schizophrenia as a diagnostic category. So noting how long things have been going on is incredibly important. So you'll see some similarities here, 2 or more of these symptoms. So it can't just be delusions because then it's schizotypal. If there's hallucinations or disorganized speech present, then we're looking more at something that's schizophreniform or schizophrenia. So 2 or more of these have to be present for a significant portion of the time. So it's not just brief, it's not just episodic, it's most of the time during at least 1 month's period. So it's at least a month, but less than 6 months. After 6 months, it turns into schizophrenia. So the big things to rule out are schizoaffective, which we will talk about. That has to do with mood disorders related to psychotics. So it's sort of the worst type of marriage you can imagine between a mood disorder and a psychotic disorder. And then you always want to rule out depression or bipolar with a specifier of psychotic features. So again, what is the most prominent thing? Is it mostly delusions and hallucinations with just some mood disorder features? Or is it mostly mood-related symptoms with just some psychotic features? So you really have to do good intake interviews to get a sense of what's going on, how prominently, how long it's been going on. And as always, we want to rule out substances, medications, and underlying physiological issues. So then we get into schizophrenia. Really interesting disorder. It's been in the DSM for quite a long time. A lot of popular media picks up on this one, and we don't really know why it happens. So for whatever reason, the brain gets activated into thinking that it's having this false sensory information and processes it the best way it knows how, and we don't really know why. There's not really any kind of research, and they've done functional MRI studies. They've done quite a bit of research on what could be causing this to happen. There is a strong genetic link. So if you have parents who have had schizophrenia, it's very likely that you will develop this too. But other than that, we don't really know the cause. And so with schizophrenia, again, 2 or more, these are going to look really familiar to the previous in schizophreniform, 2 or more delusions or hallucinations present during at least a month. And so your functioning has to be below onset. So we're not functioning super well. And continuous signs of disturbance for at least 6 months consistently. So again, brief psychotic, schizophreniform, into schizophrenia. And these things have to be at least 1 month consistently. So there can be a little break in between symptoms, but it needs to be present pretty consistently over these 6 months. We always want to rule out schizoaffective, and again, those mood disorders with psychotic features, make sure there's no other cause. And we don't typically diagnose schizophrenia with autism. That's pretty rare. So that's definitely a big rule out, is just making sure, especially with things like disorganized speech, that it's not due to some sort of neurodevelopmental or neurocognitive disorder as opposed to schizophrenia. Schizophrenia is not very common with children. Typically we see development a little bit later in life, so thinking late teens maybe for men. With women, it may not show up until the mid-20s. So we don't often see this coming up in children. In fact, it's pretty rare to have a schizophrenia diagnosis in someone who's maybe under the age of 16. And so one of the videos linked on our page as an example is Janie Schofield, who was diagnosed at the age of, I believe, 7 or 8 years old, which is pretty young and pretty remarkable. As you can imagine, because there's no cure for schizophrenia, and psychotropic medications are a little bit of a guessing game in terms of symptom management, it's a pretty miserable way to exist, especially if you have severe symptoms. So there's a huge suicide risk among any kind of client with a psychotic disorder, but especially for schizophrenia. And again, we want to factor in cultural and spiritual beliefs, because when someone says, I hear God, I need to understand exactly what they mean by that. Do they actually hear voices, or are they just manifesting and understanding a deep connection to something bigger than themselves? So don't jump straight to the idea of a psychotic disorder just because someone talks about perhaps religious-based belief systems that involve maybe seeing or hearing things or speaking in tongues or things like that. So now we are going to talk about schizoaffective disorder, which is all the worst parts of schizophrenia, plus all of the worst parts of mood disorders. So again, pretty miserable existence for someone with schizoaffective disorder, and especially difficult to treat with psychotropic medications because we have to balance out mood symptoms and we have to address hallucinations and delusions. And so it is a challenge to manage the symptoms of schizoaffective disorder effectively. We always want to rule out bipolar or depression. So again, what's the most prominent thing? Is it the mood symptoms with only some psychotic features? Or is it the psychotic features with some mood symptoms? Or is it really a balance of both? So are the psychotic symptoms present most of the time? And are the mood symptoms present most of the time? Because if the mood symptoms are not present most of the time, maybe it's something like schizophrenia with some mood symptoms on the side. Again, a huge risk of suicide, really strong genetic link, a lot of comorbidity with anxiety, as you can imagine, because the world is a pretty scary place to navigate when you're experiencing all of these things at the same time. So we have an uninterrupted period of illness where there's a major mood episode, either depressive or manic, concurrent with schizophrenia. And then these delusions or hallucinations last for at least 2 weeks without the mood symptoms. So you have this sort of switch off or balance of psychotic features that are there pretty much all the time and mood symptoms that are there consistently with some breaks. And so everything's happening at once, it's incredibly overwhelming and it's miserable. Again, we always want to rule out substances, medication side effects, traumatic brain injuries, and any other type of underlying physiological cause. And we have specifier options. So bipolar type, meaning that this person, in addition to their psychotic features, is experiencing mania. Depressive, meaning that they're experiencing depressive. You could have both, and then you have also that option of catatonia, which is where your body just sort of freezes, and it's a negative symptom that involves essentially your body is unable to recognize and meet the threshold of cues for any kind of physical movement whatsoever. So the person is very much awake in their head, but they literally cannot move their body. It's like being paralyzed. So I want to share this poem that was developed by someone named Jonathan Benjamin. It's an individual who struggles with schizophrenia, because often these psychotic disorders are what we call severe and persistent mental illness, meaning that these are present throughout the lifespan, and this population is going to need a lot of support pretty much their entire life. And it's so easy to overlook the suicidal risk of this population because it comes up so often. And it only takes one time, not taking suicidal cues seriously enough for something to happen. So this poem that I want to read to you has to do with the experience of this particular person when they went to the emergency room, saying that they have like suicidal intent. So they've gone to the emergency room and they've said, I need some help. And this is their poem representing what happened. So I will read it to you now. I want to kill myself, I told the nurse. Okay, she said, we'll need some details first. I want to kill myself, I told the doctor. Are you sure? Have you tried Valium before? The doctor got up to leave. Take one now and call us first thing, and if you still feel unwell, we'll get you in. But doctor, I want to kill myself. Perhaps a good night's sleep will help. So, as noted, often these symptoms are very intense for these individuals, and they get dismissed quite often, especially related to suicide risk. So I want to encourage you to really practice empathy and try to understand what the experiences of these clients might be as they interact with the world on a daily basis, because it's incredibly overwhelming. The last disorder we're going to talk about is catatonia. As I described, this is where you just cannot get enough physical arousal to move. And this can be used as a specifier for other disorders or as a disorder of itself if this is the only thing that's going on. And so we want to make sure that ruling out things like medication side effects, etc. But catatonia can be a specifier with substance use. So we need 3 or more of the following going on. There's a stupor, which means that there's no motor activity whatsoever. We have catalepsy, which is a rigid trance, and there's just no sensation at all. Waxy flexibility, which is resistance to movement. So this person is like a statue, and if you try to move them, you literally can't move them. They're made of cement. Mutism, where you lose your ability to verbally respond to stimuli. We have negativism, so little to no response to verbal stimuli. So this is more of a hearing related issue. So they can't respond or understand or hear your questions, for example. Posturing, so being really rigid and posturing against gravity. So bearing down really hard on a chair or another thing to kind of push back against gravity. We have mannerisms that are odd, and we use these phrases odd or bizarre a lot in terms of psychosis. Stereotypy, so repetitive non-goal oriented movements, so maybe moving your hands around, maybe moving your feet around. Grimacing, we have echolalia, which is like being a parrot, essentially mimicking someone else's speech, or echopraxia, which is the same concept, but you're doing it with movement, so you're mirroring someone else's movement.